Welcome back, everyone. So we are moving from childhood trauma to talking about sexual and interpersonal violence. If you haven't already done so, though, I would recommend that you finish going through the materials on childhood trauma and developmental trauma before moving into this portion. So that includes the videos on child abuse reporting and some of the other resources that I put in the module for this week. I think it's kind of easier to work through the materials by topic versus kind of jumping around as you work through. So that's just my suggestion, but obviously do whatever works for you. So our agenda for this mini lecture is to talk about sexual assault and rape and intimate partner violence. Both of these are heavy topics. Please feel free to pause the lecture whenever you need to. I'm not sure how long this will end up being, but especially if it ends up being over 30 minutes, I hope you'll take a break in the middle. So first, we're going to talk about sexual assault and rape. A broad definition of sexual assault is an attack or attempted attack involving any kind of unwanted sexual contact, forcibly or non-forcibly. And you can kind of expand on what this could include. It is not just about rape specifically. It can include groping. It can include forced oral sex. It can include other types of forced sexual interactions. And in general, this is an underreported crime, particularly for men, but our best estimates are that sexual assault of some kind occurs around every 2 minutes. So it is a very, unfortunately, common occurrence. And the statistics tell us that about 1 in 6 women and 1 in 33 men will experience a sexual assault across their lifetime. Again, it's underreported, so it's very likely that these numbers are higher. And some associated diagnoses, if you're kind of looking at your DSM and thinking like, well, what would if I had a client that presented with a history of sexual assault, what are some diagnoses that may come with them? And that may include frauderism, pedophilia, sexual sadism, and voyeurism. And I know that many of you have either already taken diagnosis or are taking it now. And so those may be some diagnoses that you want to go back and look at. It is important to point out that rape specifically is not a term that's used in the DSM because rape tends to be a term we use for criminal conduct. It's a term that is tied to criminal prosecution, and we don't need to conflate that with mental illness. So then what is rape? Rape is any forced sexual intercourse perpetrated by psychological or physical force, and it is a specific type of sexual assault. It is important to note that if we are thinking about the criminal use of the term, that the definition of rape can vary from state to state and what it includes and how a perpetrator might be charged. So that may be something that you want to look into for your state, particularly if you're interested in working, 1, in trauma, and then 2, with any sort of sexual assault or domestic violence shelter or agency. And so some of the highlights is not the right word, but some of the details about rape that I do want to cover with you here is that rape can come from lots of different places. And so you cannot say that it's always a result of a person wanting to, have power over another one, though that is, I think, our common understanding of rape. They're often fueled by power, anger, and or sadism. I think sometimes we talk about rape not being fueled by sexual urges, but I think some of the literature that has come out in recent years indicates that sex can be a part of the dynamic that causes a person to commit a rape. And so it's kind of all of those things, and it will be individual motivations depending on the person that commits this. Some of the most common forms of rape are acquaintance rape, drug facilitated sexual assault, spousal rape, and statutory rape. And so I just want to talk a little bit about each of those so you have a better understanding of the terminology. So acquaintance rape is also sometimes called date rape. And that will happen when someone is in some sort of relationship with a person. It doesn't have to be like a formal relationship, or they don't have to know each other super well. It can happen on a first date as easily as it can happen a year into, a dating relationship. This sort of thing we tend to also think about through like teenage assaults, where someone may be at a party and once again, this would tie in with drug facilitated sexual assault as well, but their drink is spiked and then they are raped by someone at the party that they may or may not know. Spousal rape is what it sounds like when one spouse forces sexual intercourse upon the other one without their consent, either through a psychological or physical force. So this can include manipulation or coercion. Spousal rape is a fairly new term in our, wow, the word just flew out of my head, in terms of our judicial system. For many years, people thought that there was no such thing as spousal rape, and that, like, essentially if you're married, you consent. And we understand as a culture now that that is not accurate, that a person still has the right to say no, even if they are married to someone else. And then statutory rape, again, that will vary by the law set forth in your state, but it typically has to do with the age of the person who committed the rape and the age of the person who was raped. And sometimes this will look like consensual sex between a 15-year-old and an 18-year-old. However, in the eyes of the law, it is considered rape because a 15-year-old cannot consent. I saw many cases like that when I was working at Child Advocacy Services, and I think that those are some of the most complicated cases, especially when the age gap is small. Many states will have a law that are sometimes referred to as the Romeo and Juliet law, which I don't know if I actually think that's a great name for that, but essentially there's usually an age range where you can't charge a person with statutory rape, and it could be 2 years, it could be 3 years, and that will vary as well. And so, what does this have to do with counseling? Well, many times when you are working with rape victims, you will have gotten a referral from the police. You may have gotten a referral from a hospital, somebody that's working in rape crisis, possibly, in some other mental health capacity. And so it is helpful to know the lingo. And then also it's helpful sometimes to give language to our clients. It can feel empowering for you as the counselor to say the word, to name the crime, and that can be very validating. Not always, and so you do need to get to know your client and know what they're comfortable with. You need to have a good relationship so that if they don't take it well, you can work towards repairs. But I do think that, saying to a person, you did not consent to this and it was rape, can be very powerful for them to hear. And then I just want to mention briefly some of the myths about rape, things like people who are raped deserved it because of blank. Their skirt was too short, or they drank too much alcohol, or they went off with somebody they didn't know that well. Like, all of those are statements that blame the survivor instead of the one person that you should blame for the rape, which is the rapist. Another myth is that many rape reports are false accusations. I think that myth gets, kind of tossed around because we don't want to believe that as many rapes happen that do occur. And you have to remember, this is still like pretty underreported. So most rape reports are not false accusations. There are reasons and rationale behind them. And there's also lots of reasons why people don't report, one of which is the largest is that police don't often take them seriously, or law enforcement won't take the report accurately, or they aren't, they don't feel validated. They don't feel like they can talk to somebody. So, we as counselors need to be the people that are there to support and validate and advocate and help rape survivors get the things that they need to move towards healing. So I talked a little bit about terminology already, but I will say this again. The client should determine how they refer to themselves, particularly around victim versus survivor. I did put a video in your resources where the person talks about like reclaiming the label of victim. And I thought that was pretty powerful. I still lean towards survivor. I think that victim is a term that we use in criminal justice system. We tend to use survivor more around almost any kind of trauma or abuse and mental health. So that's where I still lean, but again, I think that the client gets to decide, and if you aren't sure, you can always ask them, like, do you, when you think about your role in this, how would you label yourself? And then what does that mean to you? Which is probably the more important part of that question. And as I said earlier, naming the assault can be very validating. It can also cause like a strong emotional reaction. So make sure that you leave space for that. Don't just throw that out there at the end of the session when the client has like 3 minutes left to process it, because it is something that you're going to want to follow up with them on. What is that like for you to hear me use this term? What feelings does it bring up, or so etc. Always process, give plenty of time if you're going to give the assault a name that maybe the survivor has not used yet. I want to talk a little bit about rape trauma syndrome. As you all probably know, there are clusters of symptoms that we talk about that aren't necessarily in the DSM. So they're recognized by many mental health professionals, they're written about, but getting things into the DSM is like incredibly, incredibly difficult. And so many times we use these models to help us determine treatment. So, how do you know how to treat someone? We need to look at their symptoms. And rape trauma syndrome is related to PTSD, but it's more directly related to sexual assault. And so some of the symptoms you're going to look for are higher than usual anxiety, severe mood swings, helplessness, persistent fear, depression, rage, flashbacks, difficulty sleeping, eating difficulties, denial, withdrawal, hypervigilance, reluctance to leave home, and problems with consensual intimacy. So once again, you're looking for this cluster of symptoms, and then you would base your treatment on what symptoms are showing up in this cluster. Now, for diagnoses' sake, if you are billing insurance, let's say for this person, you may still diagnose them with PTSD or some other trauma-related disorder, but you're going to focus your treatment around the rape trauma syndrome's symptoms. And I will say a lot of times, just since we're talking a little bit about insurance and billing and things like that here, many times the law enforcement agency, whether that's like the county or the city or even the state, will have contracts with licensed mental health professionals so that they can refer out for counseling services when somebody has filed a report against someone else. When I worked at the Child Advocacy Center, all of our services were free. So all of our education services, all of our counseling, and I think that was a huge benefit because one, I didn't have to write down a diagnosis and then justify it to insurance. I could treat what I saw coming up as their symptoms. And then two, it's so much less stress on a person who's already in a state of really high distress, right? If you're dealing with a sexual assault, with a rape, and you're trying to, sort of work through the legal system, which is in and of itself very stressful, not having to pay for counseling can be a huge benefit. And so if this is the kind of work that you're interested in doing, I would really suggest either looking for agencies that do this kind of work and or talking to law enforcement in your area to see how they do contract with mental health professionals to provide these services. And in many states, there's even typically at the end of a trial, or if there's a plea bargain, perpetrators will have to pay a fee that then goes to like the general fund that pays clinicians for their work with survivors. So that's just something that I think it's helpful to know as you think about your future work. So what are the cognitive and emotional impacts of sexual assault? Some of these are going to look similar to other types of PTSD, but there are some things that are very unique about sexual assault impact. So first, emotions. I think you all probably know by now that some people internalize their emotions and some people externalize them. For someone who's externalizing, they may be screaming, crying, or even sort of laughing. I have seen laughter as quite the trauma response before. Even when I was in Sandy Hook running groups for teachers who were shot, there was always one or two that would tell their story and like laugh through it. And that is just their brain coping with it the best way they can. And so no judgment, it just is a reaction to trauma. And then the opposite of that is when we see survivors pushing inward. So they may look very flat. They may be numb on the inside and not really feeling anything. And then the second bullet here is talking about survivor's guilt, which kind of comes with all of these really complicated feelings. Things like self-blame, which will often come from our cultural messages and myths that I talked about earlier, shame, humiliation, and anxiety. These are all complicated into this like knot of guilt that can feel quite heavy to the survivor. And your job as a counselor is to help them try to untie that knot and pick apart the details so that they can feel more empowered and have the self-efficacy to be able to say like the only person whose fault this is the person who committed it. Another really common symptom with sexual assault trauma that is, of course, similar to other traumas is having problems remembering and concentrating. So you all know based on our past weeks of content that memory and the brain has a really hard time storing and contextualizing memories after a trauma occurs. And this is very, very common with sexual assaults as well. It's a challenge for the legal system, but in counseling, our goal is to help the client, form that narrative when they're ready. And through giving them time and space to do that, if memories are going to come back, they're able to come back kind of on their own, and then you can piece them together to have a more cohesive narrative. But definitely like normalizing for your clients that it's very, very normal to have problems with memory and concentration after something like this happens. And then finally, hyper alertness, again, another symptom we've talked about a lot, but particularly around sexual assault, you'll see this as compulsive protection behaviors, and that could include, kind of things that don't set off any alarm bells for me, like putting in maybe an extra lock on their door or setting up a new security system. But it can become compulsive around like, well, I need, a certain number of locks. When I come home, I need to do this routine because only this routine will keep me healthy. So it kind of borders on OCD. So your compulsive protective behaviors are a result of the hyper alertness. So you probably don't have a diagnosis of OCD, but the behaviors from the trauma are mimicking that. So early intervention is really helpful when it comes to sexual assault trauma. Unfortunately, a lot of folks don't have early interventions, and the ones who do are usually because they either decided to disclose to law enforcement or they told someone who helped them disclose to law enforcement. And then law enforcement was able to refer them out for counseling kind of before the symptoms really get stuck inside them. And so things like medical intervention, which can be really helpful if someone's worried about STDs or potential pregnancies. Also, getting a rape kit can be very helpful for the legal process. Crisis counseling, like right in that moment when the person is there, having maybe some of these medical things done, and or talking to law enforcement. It's really helpful to talk to the person about what their immediate needs are. So if they don't feel safe going back to their home, where can they go? What does their social support look like? And this could even include doing some sort of suicide assessment and homicide assessment, depending on how they're presenting. And you can use your psychological first aid training to really help you through this process and be present. Just remember that the early intervention is not going to look the same as ongoing treatment afterwards. So what does treatment look? So let's say that you're not the crisis responder, but you are a counselor that gets the referral. And, during your intake, you're going to do the same thing that you always do. You're going to be warm, but you're really going to put an emphasis on safety and compassion, which could mean allowing the client to move their chair. It could mean adjusting the light or temperature of the room. It's the safety component is almost the most important part of your initial session, because a client who's already feeling unsafe in life is going to need to feel safe to be able to continue treatment. So next, please do not ask the client to tell the story of their assault until they are ready and want to. I used to always tell my clients, like, you don't have to tell me anything about what happened until you're ready. And, we'll start where you want to. So even with kiddos, I would often start with, tell me about yourself, tell me what brings you in up to the point that you want to tell me. Or I would start with some sort of like, creative intervention to help get to know the client better. Many times clients will tell you a brief version of what happened to them that brought them in, but it takes time for them to really dig into the story. What's more important in this first session is to ask about their symptoms, ask about how they're doing, their social support, things like that. And you can use assessments for some of that, and I gave you a list of assessments here. The impact of event scale is one that I have used in the past. I personally have not used the others, but I think that they would all be fine for use as far as gathering information to help you move forward. And then for interventions and frameworks, all of these that I've listed here have empirical support behind them. So CBT and TFCBT, mindfulness, narrative exposure therapy, and exposure therapy, cognitive restructuring, and group therapy in particular can be very, very healing for sexual assault survivors. I think that even though our culture does talk about rape and sexual assault, it still can feel incredibly lonely when it happens to someone, and they go almost immediately to the blame, shame, guilt. And the group process can really help validate that they are not alone, that they did not do anything to deserve this or bring it upon themselves. But it is important to note that not everybody's going to be ready for group right away. And so asking your client about that when you feel like they might be open or ready, or just have it sort of as a standing invitation when or if you feel like you're ready for this type of group intervention, they can let you know, and then you can find resources for them or provide a group yourself. So I have a case study here for you, and I am going to read it to you. But if you don't want to listen to me reading it, you can pause it and read it for yourself. You take a little drink of water. You are a counselor in a mental health agency. You have a new client named Sherry. who is a 25-year-old female who made an appointment for depression and anxiety symptoms. During the initial session, Sherry reports that she received an associate's degree in nursing assistant 6 years ago and has worked as a nursing aide in several rehabilitation centers. She recently quit her job of 2 years and ended a 5-year relationship with her fiance, whom she was scheduled to marry in 6 months. She reports she is experiencing sleeplessness, weight loss, difficulty getting out of bed, and no interest in finding another job. In addition, Sherry described several instances of leaving public places due to experiencing breathlessness and a feeling as if she's being judged by others. During your third session with her, she reveals that she was sexually assaulted by a 32-year-old male patient at her last job. The patient who assaulted her is a man whom she attended to regularly and became friends with after realizing he did not have many friends or family visit. This patient, James, was paralyzed from the waist down after a car accident, and as Sherry spent more time with him, he began asking about Sherry's dating life and eventually asked her to date him. James then began asking Sherry to help him deal with his frustrating involuntary erections. When she laughed off this suggestion, James became more aggressive and suggestive. He would talk to her about his previous sexual encounters before the accident, and he began groping and suggesting they should have sex. At this point, Sherry complained to her supervisor and asked to be moved to a new unit. Her request was denied due to limited staff. She was encouraged to remain professional and ignore his behavior. One day, while Sherry was helping bathe James, he overpowered her and sexually assaulted her with a shampoo bottle. Due to her shock, Sherry left the rehab center and has never returned. She did not report it to her supervisor or the police. So here are your reflection questions. Does Sherry's experience meet the definition of sexual assault? What symptoms of sexual assault do you see? How would you proceed to work with Sherry? And what legal and ethical guidelines do you need to keep in mind? So if you will, take a pause here and think about these questions in the case, maybe write them out. I think it'd be really helpful to maybe, connect with somebody in the class to see how they answer these questions or share ideas. You could even use, some of your book club space to do that if you wanted to. But I think that working through these case studies is helpful because it shows you how complicated cases can be and how there are often many layers of impact and also many layers to dig through once you're actually in counseling. All right, the next part of the lecture is going to cover intimate partner violence, and I hope that if you haven't taken a break, maybe you will right now. So feel free to pause the video and stretch or get some water and come back and we can pick up right here. We talked a little bit about IPV in our risk assessment module, so some of this is going to sound familiar, but I do want to make sure that we cover sort of the basics of it so that we can talk more about treatment. So IPV is the infliction of physical, sexual, and/or emotional harm to a person by a current or former spouse or partner. This can occur in platonic relationships, dating relationships, and sexual relationships. That is missing a comma. I'm just gonna. And the abuse can be physical, emotional, psychological, or financial. One of the resources that I have for you in the module today is the gender neutral power and control wheel, which was also in module 2. But I think that that is a resource worth revisiting and also saving, downloading it for later. It's great for psychoeducation with clients. I have used it a good bit when I'm talking to teenagers and adults about the different ways that power and control can manifest in relationships. And just a reminder of the cycle of violence theory, which is a 3-way theory. It's not like a linear process. You have the tension building, the acute battering incident, which again cannot just be physical. It may be different types of abuse. and then the honeymoon phase. And these kind of repeat and can go back and forth and bounce. And many people who have experienced IPV will say that they can see that pattern once they know about the cycle of violence theory. They can pretty easily delineate what phases they may have been in or are currently. And it can be quite validating to know that this is such a known cycle that it has a name. I do want to say that while, oftentimes we think about IPV as male to female, female to male also happens. And so it's lower reported, which I think is probably something you would expect given, that a male may be less likely to want to tell the police if they are being abused, mostly based on our culture, which has its own problems. But within a female to male perpetration, you will see things like burning, hitting with objects, poisoning, withholding sex. So it could look quite different from a male to female perpetration. And then I also just want to say, there has been research done on LGBTQ plus populations with IPV, and the rates that are reported are pretty similar to the rates of hetero couples. However, it is considered to be an underreported statistic and often minimized due to, discrimination towards the population and homophobia and, other cultural aspects of folks not wanting to recognize that IPV happens across, many types of relationships, many socioeconomic statuses, many genders, and so it's a phenomenon that unfortunately, much like child abuse, you see kind of across the board. There isn't just one part of society in which these things don't exist. So there is a pretty large emotional impact of intimate partner violence. I mean, of course, this is one of the most, the relationship with your partner is one of the most important parts of many people's life. And so you can imagine that indeed it would be difficult to have your partner turn against you through violence or some other means of emotional abuse or manipulation. And so some of the most common symptoms we see are depression, low self-esteem, and that's often coming from messages from the perpetrator, PTSD symptoms, substance misuse, avoidance, numbing, social withdrawal, hyperarousal, memory loss, and body image issues or body dysmorphia. And if you've ever worked with this population or done any reading about it, you probably recognize a good bit of these symptoms as, things that you do see reflected. Many times the survivors are withdrawn socially because the perpetrator made them isolate themselves. So the cluster of all of these symptoms is often referred to as battered woman syndrome. You may have heard that in media or other areas, but it focuses on the disruption in interpersonal relationships, body image and somatic concerns, and then sexual and intimacy issues. So what are some considerations when you are thinking about assessing and treating for IPV? These are just a few, so this is not a complete list, but some things to think about are culture, gender roles, socioeconomic status, immigrant status, and religiosity. And it's important to, I think about how some of these could be protective factors and some of these could also be risk factors. So when we talk about culture, what are some beliefs or values that may be either contributing to or serving as a protective factor against IPV? As far as gender roles go, are there specific gender roles or norms that are impacting the violence? Is there a patriarchal family structure and gender norms that are expected? For socioeconomic status, are there financial implications for a person wanting to leave? And are there financial controls that the abusive partner has put in place that's keeping them from leaving? Immigrant status is very similar. Are there limitations to a person leaving an abusive relationship due to their immigrant status? And that may be more common in states where you see higher rates of immigration. And then religiosity, are there religious beliefs, which of course this could come under culture, but I think it is important to kind of consider culture, and specifically culture of religion. Are there religious beliefs that are, sort of normalizing violent behaviors towards your partner or excusing them? Are there religious beliefs that are protective factors on the other hand? And so any of those things, could be something that you want to consider when you are both assessing and treating IPV. All right, moving on. What are some barriers to IPV disclosure? And unfortunately, when we think about underreported crimes, it often is due to barriers. Some of these may be fear of the perpetrator, a fear of law enforcement getting involved, and sort of making the perpetrator more upset, or them having consequences for reporting, a fear of losing their children, a fear of losing financial resources, feeling guilty or to blame, as if, sort of that thought that like, well, it's my fault that they did this to me because I brought it on myself. Which is something that perpetrators tell their victims to keep them in the relationship and to control them, because if you feel like you're always doing it, you are always doing something to cause them to lash out on you, then you're probably not going to think that you need to leave. Or feeling that the violence is normal, and we certainly see that a lot in survivors who grew up in homes where domestic violence occurred. I want to talk just for a moment about dating violence in adolescence, because unfortunately this like facet of IPV happens more than we would like to think that it does. About 30% of adolescents experience some sort of dating violence. And if you work with teens or preteens, always screen for this. Always ask, like, are you in a relationship or have you been in a relationship? Tell me what that relationship is like. You can use those open-ended questions to find out more about the general overview, and then you can ask more specific questions about, like, do they tell you what to wear? Do they ever harm you physically, and things like that? So I think that it's really important that we talk to kids about this really as preteens, because the more they know about healthy relationships and warning signs to look out for, the less likely they're going to find themselves in a relationship where dating violence is happening. And we know that the mental health impacts can be devastating for adolescents who experience dating violence, things such as eating disorders, substance abuse, depression, anxiety, somatic symptoms, and suicidal ideation. This is a really serious problem, and if you're working in the schools, having groups and or classroom discussions on what a healthy relationship looks like is one of the best things you can do with your time. I really highly recommend that you create some sort of work around healthy dating relationships to help educate within the schools. So what are some early interventions? Again, safety is super important, making sure that the client feels safe, letting them do whatever they need to feel safe in the environment. Screening is very important. I think that if you have a good intake form, it's going to cover some of this. Now, again, clients aren't always truthful on these forms for lots of different reasons. The guilt, shame, blame, threats. If you tell somebody about this, I will hurt our children, or I'll hurt you, or something like that. But with screening, particularly, you want to ask a full family and personal history. So not just violence within their home currently, but also violence in their family of origin's home. If it does turn out that they disclose to you that they are in a dangerous situation at home, Where there is violence, you're gonna want to ask about the first and last incident, the worst incident, and any mental health or substance use issues for the client and for their partner. And of course, document all of that. If the person does disclose IPV, you also want to do a lethality assessment, which I've linked some in module 2 that you can go back to, but the things that you want to make sure you cover are the severity of violence, access to weapons, psychological risk factors, the last incident, obsessive or stalking behaviors, which often escalate over time. So that might also be something you want to talk about or ask about. Perceived threats to the relationship, and this can often be on the perpetrator side, where they perceive that maybe the partner might be thinking about leaving the relationship for someone else, or they might be involved in a relationship with someone else. Oftentimes there's usually not like a lot to that, but the perception is enough to make them dangerous. Other criminal behaviors, and then any past interventions that the client has attempted or others have attempted with the perpetrator. So in responding to a client disclosing about IPV, there are some things you want to ask and do. If you're wondering, like, well, how do I ask if someone is experiencing IPV? You can keep it simple. Has your partner ever hurt you in any way? Any way, keep it open. Do you feel safe at home? And then, of course, please tell me about the last incident. And to help the client with their disclosure and help them feel safe, remind them of their confidentiality and then also the limits to confidentiality. And, in this case, the limit to confidentiality would be if there were like children in the home that were at risk, or if the client was suicidal or homicidal and refused to go to the hospital if you needed to admit them. And then also make sure that you validate them, say, out loud, no one deserves to be hurt. No one brings this violence upon themselves. It doesn't matter what you do. You are not making your partner hurt you. Always, if you think that it's needed, assess for suicidal or homicidal ideation. But you also want to create a safety plan for the IPV. So this is different than a safety plan for suicidality or homicidality. The safety plan is specifically an action plan to help the client if they feel like the risk for them being severely harmed escalates. You do want to give the client as much control as possible, both in sessions and in the safety plan, because they have had so much power taken away from them and so much autonomy taken away from them through the relationship. And also use psychoeducation to help normalize the symptoms that they are having and assure them that with treatment and time that they can get better. We can address the symptoms and we can work on them together. I think it's really important to always leave clients with resources. We can't be available 24/7. So just like you might use the 988 hotline for suicidality, there is a national domestic violence hotline, which I've listed here. Most states have their own hotlines too, so I think that that's worth looking up. Know what your domestic violence related shelters are in your area. I know at my previous university, we had one called Peaceful Paths. They were a phenomenal institution. I donated both time and materials to them and really enjoyed getting to know some of the counselors that worked there with that service. Make sure that you have hotline numbers, both for your clients, but I think that for advocacy efforts, one of the things that counselors can do is make sure that those resources are out and about where women just are naturally, and other people too. Going back to the idea that, anyone can be in an IPV relationship. And so putting hotline numbers and resources in restrooms or waiting areas could be great advocacy. And I also think if this is the kind of work that you do, that that you're going to do and that you want to engage in, get to know your local law enforcement and try to form a partnership with them, because they can educate you and you can educate them. And together, hopefully you'll be able to help more people, you know, as a team. And that is the end of the lecture. So thank you all for your time today, and please let me know what questions or thoughts you may have that came up for you during this week's module, which was full of lots of content. Have a good one. Bye-bye.